Hi, and welcome back to the Pro PA podcast. I'm angiography, your host for this cardiovascular series. Today we're covering a true cardiovascular emergency, aortic dissection. This is one of those must-know conditions because missing it can be fatal. We'll go over the pathophysiology, risk factors, diagnosis, management, and of course, a couple of clinical questions to test your knowledge. Let's get started. Beginning with some basic pathophysiology, aortic dissection occurs when a tear forms in the tunica intima of the aortic wall, which allows blood to enter the tunica media, creating a false lumen. Dissections are caused by shear stress on the vessel, often related to extremely elevated blood pressure in someone with history of long-standing hypertension. A dissection can extend proximal or distal to the initial tear, involving the aortic valve or branches of the thoracic and abdominal aorta. This is responsible for other manifestations such as aortic regurgitation and end organ ischemia, being coronary, cerebral, spinal, extremity, or visceral. Another possible complication is rupture, which can lead to cardiac tamponade and sudden death. The Stanford classification is commonly used to categorize dissections. Type A involves the ascending aorta, and Type B involves only the descending aorta, which is distal to the origin of the left subclavian artery. Who do aortic dissections affect? This is more common in older adults, especially men between the ages of 60 and 80. High-risk conditions commonly associated with aortic dissection include chronic hypertension, which accounts for more than 70% of patients, connective tissue disorders like Marfan's or Ehlers-Danlos syndrome, anatomic abnormalities such as bicuspid aortic valve or coarctation of aorta, drug use such as cocaine and amphetamines, iatrogenic causes such as prior cardiac catheterization or cardiac or aortic surgery, vasculitis such as giant cell arteritis and Takayasu arteritis, and trauma involving rapid deceleration. The clinical presentation is usually a sudden onset of severe tearing chest pain. The chest pain is usually anterior in ascending aortic dissections or radiate to the back when it is a type B dissection, which involves the descending aorta. The pain can be an isolated symptom or associated with syncope, symptoms or signs of stroke, myocardial infarction, heart failure, cardiac tamponade, or other clinical signs of end organ ischemia, such as visceral ischemia, renal insufficiency, extremity ischemia, or spinal cord ischemia, and this is dependent on the extent of the dissection. Hypertension upon initial clinical presentation is more common with descending thoracic aortic dissections. Other common clinical findings can be asymmetric blood pressures. This is usually a difference of greater than 20 points between arms. Asymmetric pulses, tachycardia, an aortic regurgitation murmur. And when hypotension is present, this is a poor prognostic sign. It may be due to cardiac tamponade, severe aortic regurgitation, or an aortic rupture. Now, the diagnosis depends on imaging. The initial imaging study of choice depends upon the hemodynamic status of the patient. For hemodynamically stable patients, a CT angiography of the chest, abdomen, and pelvis is a diagnostic modality of choice. For unstable patients, a transesophageal echocardiogram can be done at the bedside, in the ER, or operating room. A couple additional notes are that chest X-ray may show a widened mediastinum, and an electrocardiogram might show left ventricular hypertrophy from long-standing hypertension. Acute changes suggesting myocardial ischemia develop when the dissection involves the coronary artery ostium. Moving on to the management. All type A dissections are a surgical emergency due to the risk of imminent rupture. Type B dissections can be managed medically with impulse control using beta blockers to achieve heart rate of 60 to 80 beats per minute and a systolic blood pressure of less than 120 millimeters of mercury. However, if there is evidence of malperfusion to visceral organs or extremities, refractory pain, or progressive symptoms, the patient will need evaluation for endovascular or open repair. Regarding prevention, controlling hypertension is the most important step in preventing aortic dissection. And patients with Marfan syndrome or other high-risk conditions may need to undergo routine screening. Here are some clinical pearls. Chest pain that is sudden, severe, ripping, and radiates to the back, always think aortic dissection. Number 2. Asymmetric blood pressure or pulse deficits are key clues. Number 3. Type A dissections require emergent surgery, and Type B is often managed medically. Number 4. CT angiography is the test of choice unless the patient is unstable. Then go for a bedside transesophageal echocardiogram. And lastly, number 5. Lifelong antihypertensive therapy will be necessary for these patients to prevent dissection extension or recurrence. All right, let's get some practice in. Question 1. A 60-year-old man with a history of uncontrolled hypertension presents with sudden onset, severe ripping chest pain radiating to his back. His blood pressure is 190/100 in the right arm and 165/85 in the left arm. EKG shows nonspecific ST-T wave changes. Which of the following is the next best step in diagnosis? Is it A, coronary angiography, B, chest X-ray, C, CT angiography of the chest, abdomen, and pelvis, or D, D-dimer? I'll give you a couple of seconds. If you chose C, CT angiography of the chest, abdomen, and pelvis, you are correct. The sudden onset of severe tearing chest pain with asymmetric blood pressures is classic for aortic dissection. The best initial test is CT angiography, which provides detailed imaging of the aorta. Question 2. A 55-year-old woman presents with aortic dissection involving only the descending aorta. She is hemodynamically stable with a blood pressure of 170/95. Lower extremity pulses are symmetric. Which of the following is the next best step in management? Is it A, emergent surgery, B, blood pressure control with IV beta blockers, C, IV heparin, or D, immediate thrombolysis? If you chose B, blood pressure control with IV beta blockers, you are correct. Type B dissections without complications are managed medically with strict blood pressure control using IV beta blockers. Surgery is reserved for complicated cases. Great job! That wraps up our discussion on aortic dissection. This is a critical condition that primary care providers and emergency clinicians need to recognize early. If you enjoyed this episode, be sure to subscribe so you don't miss our upcoming cardiology talks. And remember, this is the Pro PA podcast, where future pros in medicine are made. See you next time.